It's well, I guess we'll get started. I'm Nikki Rodriguez. I'm the VP of Quality and Strategic Initiatives for Integrity Partners. And I want to thank everyone for being here today for our AI and behavioral health training. And I also wanted to introduce Dr. Shaddy Saba, our trainer today. He is an assistant professor at the NYU Silver School of Social Work. And he also is a licensed clinical social worker with over a decade of clinical experience. And he's also the director of the Artificial Intelligence in Social Work and Mental Health Postmaster Certificate Program at NYU. So we're super excited to be able to learn from Dr. Saba today. And thank you so much for doing this for us, Dr. Saba. We're really excited, and I'll hand things over to you.
Thanks so much, Nikki, and thank you again for the invitation to join you all. I'm really excited to talk to folks and hear from folks about this topic, actually. So let me just um, share my screen. And um, uh, I'm not typically on dual screen, so I get a little bit confused. I'm not the AI person is not always good with all the tech, so hopefully we are good. Do people see the title here? Okay, great. So I had a very generic title a few minutes ago, and then I was like, oh, I need a better title. And I iterated with Claude. I am an avid AI user, and we'll kind of get to some use cases in a bit. But the title of our couple of days together is going to be Artificial Intelligence for Behavioral Health Clinicians, Capabilities, Risks, and Responsible Use. And these things are, these buckets are actually constantly changing, which is interesting. So today is day one of our time together. Nikki, thank you for the introduction.
So,
I am a licensed clinical social worker. So prior to becoming a professor or academic, doing research training, et
well,
cetera.
so
Oh, sorry, somebody's
we're going to
audio
have to thread
is
this needle
on.
very carefully
You can.
because she called and
Oh,
complained to Jen and
Laura, we
brought
can
all
hear
of
you,
this to me.
sir.
And I'm like, let me look into that. There.
Here, you know
Here,
what? Let me put it in the chat.
maybe I can. Oh, there we go.
Got it.
Thanks. Thank
Thanks,
you,
Laura.
Laura. No worries. I've been there. So I'm a licensed clinical social worker. My experience as a clinician is largely in integrated care settings. So meaning places where we were treating chronic pain with, behavioral health, strategies, substance use, et cetera. And as you likely know, that requires team-based approach. Also, very often like tech integrated systems in the sense, EHR, when I was practicing a lot, we were suggesting a lot of mobile apps and things like that, right? Um, I became a researcher to improve care for these, co-occurring disorders generally. And I was a doctoral student, a few years back, and I quickly kind of learned that at the time, machine learning was really the big deal in AI. I learned that, data science and technology, again, apps and things like that were could be useful for the kinds of problems we were working with. And while I was a doctoral student, large language models really, really took off. And so I've been able to position myself as somebody, with expertise at this intersection of things, right? Applying data science, applying technology to behavioral health challenges. And so currently my main gig is as a professor at NYU, where I conduct this kind of research and also teach um, a couple of different things, clinical practice broadly, but also, analyzing data for master students and as Nikki mentioned, this program on the use of AI for clinicians, like ourselves, actually for people that are practicing, it's like a post graduate program as well. And so our general kind of structure for the couple of days, or our general plan for the couple of days, and if people in the today have other ideas of things you really want to hear about tomorrow, I can try to make sure that we cover that. And also, I'd love to be a resource for you as in the future too, if I don't necessarily cover things specifically today. So, but that being said, today we're gonna kind of start with what is AI, kind of align on that question. Where is it starting to show up and where has it shown up across mental health, behavioral health? A couple of we're going to talk about that broadly, but really focus on a couple of I think some of the main use cases that are growing, and one of those is AI scribe tools, right? And then also today we'll spend some time on what are some ways that you even as a practicing clinician, may be using or may be able to use these mainstream large language models that are really the main thing that consumers are using for your work, right? Like, are there ethical ways that you can do that or not? What do you have to think about? Tomorrow, I know that Nikki collected questions from many of you, and I think rightly so. I think every single one of the questions was around responsible use of AI, right? Like, these things are really interesting and potentially powerful, but we want to make sure that we're above board and not putting people at risk, and also protecting ourselves, right? And so, how can we evaluate tools for appropriate use of use, particularly with respect to things like safety, privacy? What does the legal landscape look like? And then we're spend some time actually on this topic of, like, what do you do if your client is coming to you and saying, "Hey, I've been using ChatGPT to do X, Y, or Z thing," right? Which is common, which may be the most common form of AI in behavioral health today, right? Probably is. So we want to kind of be prepared for that scenario. So um, I am going to try to use a poll function, which I quite rarely do. So let's see if I know how to do it. Um, let's find the poll. Sorry. Okay, I swear this was like very easily available when I'm trying to see if I know how to do this. So, oh shoot. Oh, well, why don't we? There's not that many of us. Why don't we have people either um, raise hand and respond, or just type into the chat? Just maybe a sentence or so. Not super long, because we have many people and want to kind of move forward. But what are the kind of the gut feelings that people have about AI in the field of behavioral health? And actually, the response options that I had for the poll were like, "I'm all in. I'm currently using it. I'm optimistic, but I'm a little bit, I'm a little bit concerned, right? Like, I'm very skeptical, and I'm just totally like wary and against it, right? So where do you kind of fall on that continuum, or is it a combination of things? And again, if people want to use the chat or yeah, so Caitlin Jones, really exciting, but I want to understand it better. Sarah, optimistic, healthy concerns. That's a great way to say it. Sarah has healthy concerns. I think excited but cautious, concerned about HIPAA but eager to use, cautiously optimistic, um, excited to use it more. Efficiency is a concern or a desire, right? Interested and cautious, all in and skeptical, optimistic. So, I think that this is what I tend to hear from practicing clinicians generally, is that people are excited. People are, you like see the potential benefits for things like efficiency. There's this comment on integration with EHR systems, for even just things that clients might have access to themselves. And again, as people who are experienced in the field, we know that anything could carry risks, and particularly something that we might not fully understand, that clients might not fully understand, that involves privacy, um, that involves data, right? And I think it's interesting, actually. One of the uh, kind of like benefits, I think, of this current moment is a lot of us were using electronic health record systems without thinking that much about privacy, right? Like, maybe we onboarded, maybe we talked to the vendor at one point, but it was just kind of in the background. And I think now this conversation and these changes are forcing us to really think about digital systems and storage systems, right? Um, And so I'm really glad to hear people say, I both see the potential benefits and I want to make sure that we're doing this, above board and we're thinking about it. Does anybody, maybe anybody who's like, let's say, more optimistic than concerned, anyone want to kind of jump in and verbalize that a little bit in the room here? Make space for folks.
Hi, this is Margaret. I'm sorry I'm off camera right now. I apologize,
That's
but
okay. That's
it's
okay.
a screen, seeing your screen issue for me. So yeah, as I put in the chat, we're actually in the process of going through our legislature for approval to contract with an AI transcription service, and I'm super optimistic. I am aware of the risks, I believe, to the best of our ability, and we're being very intentional in our implementation. But I think from my perspective, the largest risk with a transcription service for therapy, it is really ensuring that the policies and procedures are in place, and the training for staff to ensure that they're really editing their
Mm,
notes and doing a really,
hmm.
really good job of that, and that we're auditing behind that to ensure it's happening. And then additionally, all of the consent processes that
Yeah.
that we are certain that our clients understand, that we're doing a really good job of educating them what this is and what it is not. And that they understand that if they don't want to participate, it will have absolutely no impact on their care. It's totally voluntary, that sort of stuff. I'm less concerned about like a breach of PHI just because of how we intend to use it. But yeah, those are my thoughts. I don't know if that's helpful.
Yeah. Those are both great points. Editing, not wanting to just totally hand our thinking over and actually like checking for errors totally, right? And then also informed consent, which requires us to be informed enough to provide the informed consent, right? And opt out. Laura, I see your hand.
Thank you. I'm gonna just put an exclamation point on everything that Margaret just said. So we are also moving forward with a ambient listening product in our therapy situation. The Our county AI evaluation team, we spent a lot of time going through the various products. We've vetted very many of them. The thing that they love about the particular product we chose is that you actually have to select the text that you want to put into your electronic health record,
Hmm.
which adds that additional layer of, for lack of better words, forces people to look at what they're putting in. So therefore, they are editing it, they are reviewing it, as opposed to it just automatically showing up in the body of a note.
Yeah. And I love the methodical approach that it sounds like you all took, where you didn't just jump at the first or even the second, possibility here. It was okay, let's review these. Let's kind of explore what it would be like. Let's make sure that this would fit our clients and our system and our ability to work with.
We actually gave the project to my most skeptical supervisor
Mm,
and said,
nice.
I want to move this forward. I'm all in. You're not. So this is yours to, kind of you and the program manager get to work through this together and vet it. And we turned this person from a skeptic into a let's just jump right in, all feet first. So it was good.
Very, very nice. Very nice. Risk management in action. And so, this is maybe a basic question, but actually not a necessarily easy one. So, what is artificial intelligence? Before we kind of go forward to some use cases that are specific in our area. Well, a definition that you commonly see is this computer systems, and that can be software, hardware, or both. That perform tasks that require or required human intelligence. Because as the AI gains capability, then they no longer require human intelligence, right? They now require, or they're now it's now okay with computer or computer system intelligence, right? It's important also, or maybe worth noting that the bar for what is AI has really just been shifting over, since this topic was conceived, in the maybe the mid 1900s, right? Like, there were rule-based chatbots, and now many people would look back on those and say, oh, that's not real AI. And it's kind of up for debate, actually. Um, we won't spend a lot of time there, but just to kind of also ground us in some of these terminologies that you've probably seen or might see going forward. AI is this big bucket that includes something called machine learning, which involves the use of data and statistics and computer algorithms to identify things or make predictions about things. Deep learning models are kind of advanced machine learning models. Large language models, which drive things like ChatGPT and Claude, are essentially advanced versions of deep learning, right? And they're trained on a ton of really really large data sets, and they use prediction to generate things essentially. They also use this branch of AI or computer understanding, which is natural language processing, which is computers' ability to understand and mimic human language. And so not all NLP is machine learning, but a lot of it is. And basically, large language models are really advanced forms of machine learning that involve also language. And as you're probably aware, things that involve language are especially kind of relevant for us as mental health or behavioral health providers, because so much of therapy or treatment or even our administrative work involves the use of language, right? And so this explosion in kind of linguistic based AI, it's interesting because I think, kind of pre-LLM, people thought that, the robots in the factories were going to be the things that were really, pushing people out of work, first. And it seems like actually this linguistic stuff that is sort of relevant in our area is where a lot of the changes are happening. But to kind of move to things that are, concretely relevant for us, a couple of like types of AI, and so the slide that I just showed, like the technologies might show up in these different types in different ways, and we're not going to get too technical here, but so predictive AI, again, is kind of the one of the building blocks for LLMs, but there's a lot of predictive AI that's not LLMs, and it's when you can have train a statistical model using data to identify, right? Like if taken all of the EHR data that we have or that these large health systems have, I've trained a computer algorithm-based model to be able to say, okay, when somebody shows up with this level of depression, with this socioeconomic background, with this age, right? Like, what is their probability of depression, right? That's a predictive algorithm that you can train in a machine learning or predictive model, right? So some examples are based on somebody's intake data. How likely is it that somebody has depression? And just to flag, I'm going to show some. We're going to talk about some specific like products or more specific examples of these, but wanted to kind of give again some definitions, right? Will somebody, based on the data that we have that they're showing up with, will they be readmitted in 30 days? That's a hypothetical example of what you could do with predictive, purely sort of predictive AI. Um, we're now in this world where, very often when we're talking about AI, we're talking about generative artificial intelligence. And essentially, it's taking that predictive technology and using prediction to generate new content. That's why people kind of refer to them as, in some cases, like really sophisticated autocompletes, because it's kind of saying like, what's supposed to come next, right, in this paragraph or in this sentence. And the architecture is really complicated, and it uses essentially, like, often uses like all of the data on, not all, but like a lot of the data from the internet, Wikipedia, books, etc. They've trained these generative AI models. There are non-language generative AI models, right? Like there's video generative AI, there's audio. Maybe you've seen some of those, like music generators right now. But really, we're going to spend a lot of our time in the linguistic area, right? And so large language models, so things like ChatGPT, again, Claude, Gemini, are mainstream large language models that are essentially, a linguistic generative AI, right? And because of the technology and what they're capable of, they allow us to have more, like more flexible or more nuanced chatbots, right? That can, kind of understand or seem to understand a little bit better, generate based on context better, right? They can help us draft, translate clinical materials. We'll come to some examples of this in a bit. Um, and then we're moving also towards agentic AI, which are systems that can take actions autonomously. And largely today, when we're hearing about agentic AI, it's kind of extensions of this technology here. It's like a large language model that's plugged into maybe a coding tool, maybe able to access the internet, maybe to come up with a plan using language and then follow the plan, right? But there's other forms of agentic AI that are not necessarily based on this technology. But some examples of what we can do with agentic AI, get really in-depth research, on a specific practice topic, by consulting a lot of different references and summarizing in a planned out way, creating things like practice, websites for our practice. And I know I have some master students who have like thought about doing software and things like that, right? So the field is really blowing up with generative and agentic AI. Um, you also you will encounter simpler things that, again, going back to this concept of like, some things that we used to call AI, some people say, oh, that's not real AI anymore. But like, a EHR system that just based on, the DSM criteria can kind of do a decision tree, right? Or based on some pre-loaded rules can do a decision tree about diagnosis, or these really, again, older chatbots, where people were just scripting in responses like, if somebody says sad, respond, why are you sad, right? Those are examples of rule-based AI systems. And when I say that it's more predictable, it's interesting because there's this kind of trade-off between generative systems that are, again, sophisticated, including context, and then these sort of more traditional predictive and rule-based systems where once the model is what it is, you're always going to get the same response versus, as you've probably noticed with a generative system, even with ChatGPT, like if I ask the same question twice, I'm going to get a slightly different response. And so we can think about trade-offs clinically there, right? Like, and if maybe I want a chatbot that's always going to say the same thing, if it's a clinically acute enough or potentially risky enough problem, right? Or maybe there's cases where I want it to feel like you're talking to a person. So there's some trade-offs that we're going to come back to those in a little bit, actually. So now moving from this kind of on the last slide, we were talking about like, essentially the technology that undergirds a lot of this stuff. And now we're going to spend some time just doing a little bit of a lay of the land of like, where are these kinds of things showing up across the mental health landscape, right? Broadly. And so screening and triage, so people, again, on that last slide, we noted that a lot of these are sort of machine learning based tools where, given how people, are presenting or the data that we have on them, where should we direct them, what would be helpful, what might happen with them in the future, what might work, not work. And one, I think probably the most largest deployment of an AI tool in any health system, besides nowadays, I'm sure, like ChatGPT's, for healthcare, or even just, like I said, people using it kind of ad hoc, you could probably argue is maybe the largest deployment, right? But the largest like specialized mental health or behavioral health deployment was this NHS Limbic Access. So NHS is the health system in the UK, right? And it is a conversational AI chatbot. Kind of looks like this on the phone, on the cell phone. Um, People join, or people kind of engage the service, and the chatbot screens and triages patients before they talk to a clinician, right? And so Limbic is claiming. So I've presented versions of this in the past, and like I keep upping this number because a year ago it was 400,000. I talked to some folks a few months ago, it was 500,000. It's probably 600,000 or 700,000 now, right? So let's say hundreds of thousands of patients have been screened. Limbic claims 93% accuracy for provisional diagnoses, 50% reduction in screen time. We're going to talk in a little bit about, maybe this number actually is a little bit deceptive, or doesn't capture something that we wanted to make sure that we know. But on the surface looks pretty good, right? And this is certainly a nice number, reducing the time that it takes for screening. When we think about systems in which people are underserved, or there's not a lot of services, or populations that are underserved, um, they've reported in a study before that there was especially higher rates of referral, or people kind of engaging with the service themselves. That's the self-referral for minority, race, ethnicity folks, non-binary folks, et cetera. So the kind of along with the idea that technology can support in areas, or among folks where where there's gaps, right? um, Kind of along the lines of screening, like the sort of a next step following screening is treatment matching, right? I just want to see if there are supposed to be more bullets there, but so when we say treatment matching, it can mean a lot of different things, but one thing it has meant and can mean, um, so once you are able to identify characteristics of somebody, can you also identify with whom or what treatment, or what kind of treatment, right? Is going to best support them. And so one example that's been deployed is Spring Health's therapist matching tool, which is a client-facing tool. Anybody can access this website, can input their information. And it's kind of like if Psychology Today had AI built into it, like the person puts in, again, their characteristics, maybe their preferences for, I want to see somebody who talks a lot, or I want to see somebody who gives me solutions, right? Versus somebody who kind of, works towards insight, right? Um, Things like that, and then does some kind of algorithmic matching to therapists and treatment modalities. But we can think about also how that can be useful, even like people are involved in a specific clinic, and here down in decision support, can we match them essentially to specific um, modalities, right? Can a psychiatrist match them to a specific drug, right? Based on their clinical history, based on biological data, et cetera. And so VA has a number of clinician decision support tools as well, where based on, again, person's data and the algorithm that's been trained, how likely are they to develop a risk for overdose, right? If somebody prescribes them an opioid, or what's the suicidality risk, and then these EHR systems that are linked to these algorithms can say, oh, have you linked this person with behavioral health, or with a different kind of pain treatment, perhaps, right? Um, where we'll get in a second to the scribe tools, because really scribe tools in a large way kind of just involve all of these things, right? Or at least some of them do. I guess some of them don't, if they're just transcribing and then giving you a summary, right? But we're moving to a system where scribe tools are doing many of those things. Again, both today and tomorrow, we're going to talk about, well, today we're going to talk about, kind of LLM use and mainstream LLM use for people like us, for clinicians, and tomorrow we're going to talk about mainstream LLM use for clients. But besides the mainstream LLMs, there are chatbots that have been and are being developed specifically for mental health, right? So maybe you've heard of Wobot. Well, Wobot was kind of one of the first with research evidence, and now it's shut down. And I'm not totally sure why. It seems like it was around the time that ChatGPT was blowing up. Maybe they kind of saw the writing on the wall and thought, oh, we're going to just kind of be swallowed up by these mainstream tools. I'm not totally sure. I think they're working on other things, but there's also, WISA has been studied with a number of conditions. Therabot is, one with RCT evidence, or at least preliminary RCT evidence. And generally, the evolution of these systems or of these chatbots has kind of looked like this. They started, actually, it's interesting. I kind of forgot to, I guess, to talk about this, but the first chatbot, I think was in the 60s or so. I could be a little bit off there, but it was actually a mental health chatbot. Somebody, Weizenbaum, developed this chatbot to mimic Rogerian therapy. And actually, he did it in such a way where he was trying to show like, oh, Rogerian therapy is silly. Like it's just repeating what people are saying. And what he kind of was surprised by was that his administrative staff and the people that were using it actually really, really liked talking to the chatbot, right? And it was called ELIZA. And so if you've heard of the ELIZA effect, it's because people, kind of get feel benefit again from sitting with a system that is kind of responding to them in that way. And that was sort of a rule-based. Oh, oh shoot, what is happening here? That was sort of a rule-based system. We moved, but with the pre-LLM, we moved to these like systems that could use machine learning to better understand what people were saying, right? Like using algorithms. And now with generative AI, I think Therabot is an LLM based or generative AI based system. Again, more flexible in terms of sounding like a person that's maybe with some like it's not always the same thing, and it varies, and it has context a little bit, right? Now, what I want to say is that even in the case of these when there's been RCTs, um, there's promise here, right? Like people are showing like, oh, it can be an adjunct to care. It can help reduce, maybe symptoms of depression. It can help with things like pain, right? Like help reduce a little bit, right? But that being said, we have to also be aware that this is very, very preliminary data at this time. The RCTs are often versus waitlist control. Actually, to my knowledge, they've always so far been versus waitlist control. So it's like there's improvement versus people that are actually not doing anything, right? um, and with all digital health tools, right, like even the mobile apps, engagement is a challenge, right? People might use these for a couple days, then they might say, okay, I'm getting bored of this, or I've been helped enough. And legitimately, maybe for some people, such support, such sort of minimal support is enough, right? But for people that we work with, maybe it is, maybe it isn't, and the data is just not there yet. This point is really, really important. So the Therabot RCT, it's almost like you have to dig into the paper to see this, but they often had to use human intervention for safety concerns. So like if the person was expressing suicidality, or the chatbot said something, responded in a way that was not that was not helpful, somebody had to be watching that and intervene, right? And so we're not nearly at a place, at least with these things, where we can just kind of let them loose on people. We need human in the loop. Oh, my mouse is being a little bit odd. I might actually just turn off. Well, sorry. I think this mouse is maybe um, low on. So I'm gonna just apologize. I'm gonna switch to the laptop so that I don't keep doing this. The laptop screen. me to.
It looks like Dr. Saba had to get out of the meeting, and I'm sure he'll be coming right back in.
Okay, very, very sorry. I did not mean to close my entire system down. So again, the AI person is not always on the technology. So okay, sorry about that. Um, so moving now, beyond, we've kind of been this last bullet, we've been in the space of like intervention, right? Like, a chatbot can deliver interventions. In fact, we could also have talked about like mobile apps more generally, right? They're probably building in AI, into things like the VA apps and things like that. Certainly, what's it called? That the headspace, right? I think has an AI function now. But one of the areas that was really blowing up when I was, starting to get into this space was the use of wearables, the use of kind of passive sensing to do what we were talking about on that last slide, which is to like take in your data or somebody's data, to take in their um, physiological signals and to identify using the physiological signals either current problems, right? Like, is stress up? Are people not sleeping? And then to say, based on this risk profile, is somebody likely to kind of have an increase in some kind of symptomology in the near future? And so, actually, a lot of the research that I've been working on with some collaborators involves things like wearables to identify PTSD symptoms or risk of increasing PTSD symptoms in veterans, for example. Um, and so one of the potential like benefits of this, if this technology, really pans out, and I guess people are starting to do this, is just-in-time intervention, right? So if I have a, risk of a spike in symptoms in the next, day, maybe my phone can kind of prompt me to do a mindfulness exercise or actually learn what's beneficial for me, again, based on machine learning and based on my input and what's happening now is as we have generative AI and things like health coaches built into even Google released this new Fitbit with a health coach, right? And the health coach is going to be constantly sort of learning about me and asking me questions, and you can imagine in the future a system that's linked, your devices are linked, your chatbot is learning about you, it's learning what's useful, and it's telling you, it's telling you or your clients, now might be a good time to talk to somebody or what have you. And so one FDA approved kind of like early, I guess, or rudimentary, I guess, example of this in some ways is the Nightwear application, which uses Apple Watch to detect and potentially interrupt PTSD nightmares. Some of the data that I've seen on this is, it's not perfect by any means, but it's a technology that people are working on very, very intensely, you can say, right? So I think in this case, your watch like taps your wrist if you're asleep, and it detects nightmare, right, to kind of get you out of the nightmare. So, it seemed from the participation in the beginning of the session today that people are thinking a lot about the AI note scribes or integration in EHR systems, and I, from my like, I guess what I've seen, in terms of what people are developing and from my experiences as a clinician and what intuitively feels like it could be potentially helpful, potentially useful. Um, and again, where it seems like a lot of the effort is going by these developers. I think the AI note scribe is going to be the place where we as clinicians sort of see the most advance and the most rapid advance. And by advance, I mean like deployment into our, our care systems, in the near future, right? And so, as I said earlier, at the most basic, a lot of what these things are doing is simply kind of listening in, transcribing a session in order to summarize a session, right? So that, which, as you likely know, like relieving the burden of sort of doing a full note without such assistance, right? And I have secure storage as a basic function, right? Because as somebody mentioned, hopefully if we're working with the right, vendor and these are reputable and they know about HIPAA and all that stuff, like that should just be a thing that all of them have, right? Is data security and privacy. But we have to also be careful and make sure, and we'll get to that a little bit today and more so tomorrow. But the other kind of emerging features that likely many of you have seen is not just summarizing sessions, but actually taking that summary and putting it into a format that that plugs into our typical recording processes and procedures, right? So making a SOAP note or a DAP note, right? Identifying here when I say treatment planning, case formulation. So some of these, I think Blueprint has this. I think, as far as I know, I think like Upheal maybe has it. Maybe a bunch of them do. But like being able to kind of identify a thread in the what we've been talking about from session to session. You say, "Hey, I'm a CBT therapist," or "I'm a psychodynamic therapist. Can we formulate this case or write this note in a way that that kind of brings forth CBT relevant content? Can we suggest worksheets or interventions verbally, right, to people based on the kind of therapy or treatment that that I'm doing with them, and also flagging risk, right? Like, saying, hey, like, you talked about suicidality, or you talked about this person has history of suicidality, and today, these were some risk factors that have been coming up. And then finally, on the administrative side, as these systems are, like growing in robustness, or a lot of them actually are being built to integrate directly into existing EHR system. But a lot of these companies are developing, ways to automate billing, ways to automate scheduling, ways to, or assist with scheduling, assist with like, a risk is flagged. Let's automatically notify supervisor or colleague, and you can imagine like, oh, medication issue. Let's flag the physician, right? Want to also just note that, like, there's a number of examples. There are obviously many others. I think, folks on the call today mentioned a couple I hadn't heard of. But there are like essentially many ways that this is rolling out, right? Some existing EHR are just adding AI features. Some of these like started as sort of simple transcription and summarizing tools, and they've kind of built out from the bottom up to become these more again, robust functional systems. Some of them are, some of these folks are developing tools that you can plug into EHR. I suspect, like, companies like Epic and, in the next several years are going to try to just dominate the market by saying, oh, you already use my system. Like, well, why would you, add something on if I can, deploy something that's doing all of this stuff in a useful enough way, right? So we're going to have rapid changes, I think, in this space. Preliminary research, again, I think this is going to be a common theme here. This like lack of strong evidence for improved outcomes, because again, this is such a nascent space. People might market them differently. They might say, "Oh, with our internal data, we're seeing this, we're seeing that." But we've got to be critical about that in the sense that many people are just trying to market products to us, right? But that being said, aside from clinical outcomes, right? Like aside from benefiting the treatment itself, um, there has been evidence that people are clinicians like ourselves are reporting increases in satisfaction. Note taking time can go down. Um, there's a qualitative study here that where people talked about like it feels like I have a supervisor in the room with me, right? So in some sense, like there's the promise of these are almost useful, may almost be useful as like training tools, right? When for they're helping us formulate cases and things like that. Um, but um, uh, as somebody verbally mentioned in the back and forth earlier, we have to be aware of like what they miss or the fact that they're missing a lot of things or potentially missing things or potentially making errors, right? Um, so it could totally make up in the same way that you've probably seen ChatGPT. There's also like they're limited by how well the audio transcription or the audio even records in the first place, right? There's sort of a limit to how well a microphone can pick somebody up if they're across the room and there's a lot of other things happening in the building. Maybe it's picking up audio from outside. Um, and if they're purely audio based, is not going to be picking up nonverbal communication, obviously, which is something that we, as experienced clinicians, are likely to be picking up ourselves. Um, not picking up our reactions, right? What happens to transference and countertransference if we're just relying on AI scribe tools. Obviously, again, these are in many cases have likely been trained in a specific cultural context, right? A US or Western context generally. And if that's the case, maybe there is even linguistic nuance that we're missing from non Western like folks from non-Western backgrounds, right? Um, so if we are using these, and I want to say like I don't see my job as telling you to use something or not to use something. I hope hopefully I think my job and the job of this training is to just kind of have us become more familiar or have a conversation with ourselves about these things. But I think one thing that's important is just helping us be prepared for making decisions for ourselves and then also like what do I do if I decide to use something like this, right? And so you've probably thought about this yourself, but the point these can be helpful for enhancing but not replacing clinical thinking, right? Because they're where well, again, what happened to countertransference, what happened to nonverbal, what about the errors, right? And so as somebody mentioned, exactly, I think she exactly said something like this statement, right? Like notes that are generated are first drafts. They need careful review. And even if they're perfectly um, accurate with respect to like what they do say, what do they not say, right? What from your own clinical wisdom and subjectivity, do we need to add to this conversation? Um, so I'm going to we'll have a little bit of discussion on this in a second, but I have a video. Okay. Share. It took me the longest time to know how to make sound happen when I share video. So I think I know now. Do we have fans of the pit on the call? Um,
Yes, and that was horrible when are you talking about when everything went down?
oh yeah, yeah, we're gonna talk about that too. Um, for sure. Okay, let's make sure this. Okay, and people see the pit screen or the YouTube screen,
Yep, we
right?
see it. I see it
Okay, cool.
anyway. Yep.
All right, great.
Yeah.
Thanks. Okay, so this,
I'm Dr. Al-Hashimi.
Nice to meet you.
Nice to meet you. Ma'am, this is a teaching hospital. Is it okay if some of our trainees join me?
Not a problem.
Stevens, I have an app on my phone that can listen to our conversation and the details of my physical exam and write it all up in your medical record.
Wow.
It's protected, confidential, doesn't even stay on my phone. Dorsalis pedis and posterior tibial pulses 2 plus and equal. Your exam is perfect, ma'am.
Oh, that is good to hear.
I will be back when your blood tests are ready. Let us know if the chest pain returns.
Thank you.
You are so welcome. What do you think?
Well, I don't think it's cardiac.
I mean, what do you think of the app?
I mean, it's hard to say without seeing the full thing.
Take a look.
Oh my God. Do you know how much time this will save?
Studies show you can spend 80% less time charting. You'll get out of here sooner, improving both patient and physician satisfaction.
Oh, excuse me. It says here she takes Risperdal, an antipsychotic. She takes Restoril when needed for sleep. So is that,
AI. Almost intelligent.
Generative AI is 98% accurate at present. You must always carefully proofread and correct the minor errors. It's excellent, but not perfect.
This is amazing.
I'd hoped you would have reviewed my ideas for improving the department. I was looking forward to getting some feedback from you.
Okay, well, I think the department functions pretty well, all things considered. I mean, we face the same challenges that most emergency departments face.
Let's take generative AI, for instance. ER doctors spend 40% of their time charting, only 28% of their time at the bedside.
That doesn't sound accurate.
I've included the study in my packet.
Right?
okay, so well, so yeah, there obviously that was a medical example. I'm a fan of the pit, and I think it captures though our kind of the trade-off here pretty well, right? The actually I think the 80% reduction in note time is a actual I've seen a study that says the same thing. I was surprised at the 98% accuracy. I have a feeling that's overstating it. But what are people's reactions to either the video or to this topic more generally, right? Which I think is captured by the video, but also we had a kind of broader slide on it. Like, what did you see in terms of potential benefits and concerns?
I think the staff skepticism is something that, needs to be overcome. I had forgotten about that episode. And then of course, I guess just the errors. I mean, so we've been sort of piloting our system that we're going to be using, and I'm not using it with patients yet, but I've been using it for meetings, like meeting minutes, and you definitely have to, make corrections. It does make errors for sure. It has trouble sometimes determining who's speaking, if you have a whole group. And so, it'll indicate that so and so said the following things when it was someone else, things like that. But I think in that episode, at any rate, I think there was just a lot of skepticism,
Yeah.
and I think people sometimes feel like maybe it's going to take away from their utility,
Hmm.
that they feel threatened in some way by that.
Yeah. Yeah. So there's a whole like what if it's too good, right? Or
Yeah, like what
there's
if
a
it's
threat
better
maybe.
than me?
Yeah. Yeah. Yeah, that's a good additional point for sure. It's funny, you mentioned the errors, and I didn't notice this the first time. Well, the first like three times I watched it actually, but she says minor errors, and it's like that wasn't such a minor error.
Yeah,
That was
really,
a
like that would have been a
medic.
major med error, by the way.
Yeah, exactly,
Yeah.
exactly right. Yeah, and so I've noticed, I've use these things and seen them in action. And I've had instances where it will output. There is no risk of suicidality, right? But it was actually just that it didn't come up in the conversation. And so that's an overstatement of what was said and not said, right? It would have been more accurate to say, suicidality wasn't discussed, right? And so again, like an example of, maybe Dr. Al-Hashimi would have said, oh, it's a minor error. Well, no, that's not a very minor error. That's a pretty important thing to get right, right? And so we want to be very careful in our use of these. Other reactions. Are people using these? Are people finding them helpful? Or how are people using these in kind of viable ways?
I think that I'm not sure this answers your question, but I don't necessarily, we won't be using it for like diagnostic purposes or anything like that, which is obviously different than in an ER setting I mean, we're really just using it for ambient listening. And I would be hesitant at this point in the infancy of the field to use it, I think, for anything more significant. I mean, the service that we're purchasing will have a research component to it for our docs. Like they can, you know, they can cut and paste in all the medications the patient's on and ask like what would be the next, best option for, prescribing when they've non-responded to the following things. Um, but that's just pulling from, I forget where they say, but they're pulling from an existing tool that a lot of clinicians already use that I
Mm.
think has been proven and pulls from like clinical studies and such. But I would, we won't be using it for any sort of lethality assessment or diagnostic purposes, and I would be very hesitant to do so at this point.
So this is a really great point. You're saying I want to stay over here in the more basic function, and because like this bucket over here probably requires personally requires stronger research evidence. Um, and that's a really good point, right? Like, if a tool is formulating a case, is it doing so accurately? If it's flagging risk, is it doing so accurately? As we move into, put this bullet of like it's doing things, but it might be missing things. Like, we have to be a lot more careful if we're handing over some of the risk flagging and handing over some of the case formulating. And so maybe for some of us, there's a way to, stay in the more sort of basic functionality. And even still kind of check for inaccuracy and be very careful about inaccuracy. So I see a question in the chat. Is there a difference between uh, in these language AI systems versus larger AI, such as image and video creating AI? Many clinicians are conscious about the danger of AI on the world at large, as well as the dangers, of kept transcripts, legal ramifications as well, uh, belief that AI information is public domain, yep, held transcript. So a lot of, there's a lot of kind of nuance to what you're asking here. I mean, certainly, with the image and video generating AI systems, I think you're probably in the realm of like the consumer facing tools, right? Like the ChatGPT image generator, right? Like, and so that system, certainly is going to lack a lot of the protection that a tool developed specifically for a clinician, to be deployed in a health system, will have. To your kind of second bullet or bucket there about the legal ramifications and public domain, we're going to talk a lot tomorrow about privacy and the sort of the murkiness of privacy with respect to, both both things that are sort of just developed special to be specialized products for people like us versus again the kind of the consumer facing or the mainstream ones. But there's murkiness to both, and there's murkiness in different ways to both, which I think you're getting at in your second message there. And then the point about the world. Um, oh yeah, the kept transcripts. Yeah, similarly, that's a murky potentially thing. Depending on the product. We'll get into that tomorrow too. We can be a little bit more, I guess, just to partially answer the question. We can be a little bit more confident when, again, when they're companies and tools that are developed specifically for us, and they have very clearly laid out policy, and they're very transparent when we ask them questions, right? Again, versus, um, but there's still things that we want to be aware of with the murkiness, which we'll talk about. But we can be more confident there again versus like, I'm just inputting my information into something like ChatGPT or my client is. Then we're far less confident at all, if at all confident, actually. Um, so great, really important questions. Um, Okay, so why don't we take a break until 2:00, you know, we'll just do 5 minutes. I'm cognizant that it's 2 hours on Zoom and maybe people want to step away for a minute. Um, so I'll jump into we'll kind of pivot to these mainstream LLM systems in a second when we come back. All right, we'll start off in another 30 seconds or so. Okay, so that felt like a good pause point because we're pivoting from, well, we had done, like introing the topic, a little bit of definitions and broad use cases, and then spend some time on this AI scribe slash EHR area. Um, Now we're going to spend some time really just focusing in on like, are there ways in which these mainstream LLM tools, which are where a lot of the action is happening with AI generally, are there ways in which they can be useful to us in our work? And so just maybe we'll do quick show of hands, or I guess there's like the up, uh, the thumbs up or the thumbs down. Maybe we can do like reactions. Like, are people using um, say ChatGPT, Claude, Gemini, etc., are people using these kinds of tools for work at all, right? You don't have to say, this is what I am, this is what I'm not. So I see thumbs up. I think I see several thumbs ups. I can do it this way. Yeah, I see at least a handful of thumbs up. Yeah. Me too. This, in the context even of this presentation, I mean, finding information, summarizing information, brainstorming, rewording, right? It can be really nice as almost like a um, what's the word? Almost like a thesaurus for sentences, right? Where like, how do I word this in a bit of a better way? Big picture, like, right? Like what's the best kind of sequencing for this thing? And checking sources, right? There's this kind of interesting like you know double-sided coin with these systems is they can like make things up, but they can also be good at checking accuracy if you give them the right context to, right? If you upload a paper and say, hey, is this what this actually says? Or like, like check the sources on this, right? And give me a sourced response, right? They can kind of help us with that kind of accuracy checking. But so I'm going to just kind of go over some big picture ideas, of ways that these things can be helpful. And we'll talk on the next slide about like, a little bit more of a how in terms of like, how to maybe more effectively interact with these systems. Um, but even there's, kind of example prompts on this slide too, right? So some things that I've seen others have done with these kinds of tools. Generating clinical material, right? So like, I want a handout. I want a CBT based handout, on sleep hygiene, for this kind of person. Use accessible language, three concrete strategies, right? Um, Translating material, right? I have this existing handout, or I have this existing information that I hand out, or I have this, this template of a client message that I send out, right? Can you translate it into Spanish? Can you translate it into, a different language? Can you reword it, right? Like in a way that, maybe, frames it from maybe it's generic and the person is struggling with a specific kind of a relationship issue. Can you reframe it in terms of this kind of relationship issue? Um, right? Brainstorming and conceptualizing, and again, we'll get to on the next slide, like obviously not inputting real identifiable information, but I have somebody who's generally struggling with this kind of challenge. What are some questions that I can ask from a CBT or from an MI perspective or from an ACT perspective, or what are, generally speaking, like what somebody that struggles with agoraphobia, right? Like how does ACT conceptualize this problem? And what are some questions that I could ask to get at it from an ACT perspective, for example? Um, Again, I kind of pointed to this earlier, but like engaging with clinical or academic material. I'm uploading a research article. Can you summarize, key findings? I don't have time or the expertise to understand the research methods like super concretely, but kind of break down the research methods for me. Like what do we not know given that they did the study in the way that they did it? What are the limitations? What are the clinical, implications for the kinds of folks that I work with? And then these last two are kind of like agentic, examples of, again, the line is blurry, generative agentic, but like these are, I guess you could make the argument, these are more agentic examples. Find and summarize some recent studies on this treatment for this kind of population, maybe draw from similar populations if you're not finding this exact one, but tell me that it's limited in the ways that it is and making the connection to the population, right? But again, break it down statistically, give me effect size, give me limitations. And then you can upload paper and say, hey, this is what you said broadly, like let's dive into this paper a little bit more deeply, right? Help me build a website or some marketing material for my practice, right? I have students in the master's program that have done some really impressive things with we had an assignment where I had people compile the clinical materials that would be useful for them going forward following their social work education, and somebody just made a website with their sources, and it was really nicely done. It's beyond my ability, but AI is kind of giving us this, or potentially giving us this ability to stretch in that way. So how then, assuming that we're, curious or interested or are kind of using AI or using, the mainstream AI tools in these kinds of ways, are there some guidelines or what are some things to kind of think about to make sure that we're doing this relatively effectively and definitely with safety and things like privacy in mind? So these are some things, there's maybe I could have linked to this, but I'll share these slides and I'll update this with a specific link. There's a person, Ethan Mollick, who does some really good, just how to keep up with the advances with the general systems, right? And how to kind of work with them, effectively. And so some of this stuff I'd say I gleaned from him, and some of this stuff, you just kind of in working with them, you pick up, right? You pick up sort of an intuition for what works for you. It's really this interesting space where maybe your guidelines would be totally different based on how you're using it, right? And so but some things that tend to be true is the newer models are just better, right? Like this field is advancing quickly. Turning thinking or reasoning on, generally leads to more, more well thought out or more accurate, more helpful responses. This often, will require the $20 membership, if you're using them relatively frequently. The $20 tier is usually helpful for having thinking on and using them regularly, right? Otherwise, you'll run out of tokens or whatever it's called, right? But specificity is also really important when you're prompting, right? So instead of just saying I want a CBT handout, right? Then it could look any number of ways, right? But I want a one-page handout, not just CBT, but specifically cognitive distortions. I want, it's not just for anybody, it's for a teenager with anxiety. You could even get more specific, right? Anxiety about, classwork, anxiety about, peers, anxiety about, talking to, romantic interest, right? The more specific, oftentimes the better. And so I like asking this or including this is, before you do it, let me know if there's anything else that would be helpful to know, right? And ask any questions that would make your response better. Treating the output as a conversation, right? And so it's often the case that there will be some things you don't love about the first one-page handout that you get, and so you can say, hey, I think rewording the section on cognitive distortions, maybe to focus on this kind of problem, or to the person's this kind of you directed it to a female. They're actually not a female, right? Like something, things like that. You can also obviously, if it's outputting it as a Word file, you can then take it into Word and edit it. Sometimes that's kind of the quicker thing at a certain point, right? Um, Providing source material, right? So nowadays there's like several ways to do this. You can create a project in some of these, in both like ChatGPT and Claude, and you can have in the project there's the several maybe PDF documents, or the training material, or whatever it is, right? um, or you can upload them into the specific chat and say, hey, ground your response just in this CBT manual, right? And then you're sure that the one-page cognitive distortion handout is derived from what was contained in the CBT manual that you uploaded. Sometimes that's a little bit limiting, right? Like maybe the training data has a wider array of things that are useful, but sometimes you could say, hey, make sure it's accurate, but also like you can, maybe more than I'm uploading, right? Um, and then it's interesting how these things can still hallucinate sources, meaning they can make sources up. Um, but generally, a pretty good way to control for that is to say, make sure this is sourced and give me the source and give me the link to the source, right? And then you can click on the link. The link definitely exists. I would say even still, when it comes to things like complex or nuanced research evidence, they can make sort of big picture claims that are a little bit out of line with what the study actually says, or maybe like it's less specific than the LLM will say it is. And so you want to do a lot of like citation checking and source checking if you're putting out information as truth that like may or may not be um, that's something that you're saying is from a study or something like that, right? um, I think this last point, I would just say like the farther outside of your what or what you're familiar with, or what your scope of practice or your knowledge is, the more risky this gets, right? Like if I have no experience in cognitive behavioral therapy at all, and I'm like create a one-page handout on cognitive behavioral therapy, like the output might look really good to me, but it might make some really basic errors in how it's explaining things, and I don't know that because I don't have the experience. Versus if I'm super experienced, but I just want to save the time, and maybe I then get the output, and then I make some nuanced and some expert level edits to it because I have that expertise, right? So in that zone where you're co-working as an expert with, again, something that's kind of enhancing and like almost like building onto your own intelligence, that's when I find these kinds of uses especially helpful in my work personally. Um, so just a couple of, I think we've kind of touched on this to some extent, but just to kind of, um, make sure that we're on the same page here. They can generate incorrect information, including making up citations. That's why I like to say, give me a link to the citations that one, I know that it exists, and then two, I can actually look at it. They can reflect biases in training data, meaning, right, like the most of what is included in the data sets that help train these things is again writing that was generated in a Western context, which may or may not be relevant for the specific person or problem that you're working on, right? Or there may be a kind of things that you want to check. Tendency towards sycophancy. So you've probably heard of this, and if you've worked with these things at all, you've probably experienced this, where it's pretty easy to get them to say that you're right, right? Like even if, maybe on the first pass, that you don't totally agree with, or you see something that you think is wrong. If you say, oh, well, you know, this is how I'm thinking of it. Isn't this true? Like you can kind of get it to agree with you. Um, and that's not necessarily uh, uh, like you just want to make sure that that you're being thoughtful and not just saying, oh, well, it's telling me I'm right, so I must be right. There may be more nuance there, right? And we'll get into more of this tomorrow when we talk about LLMs for if a client is using these systems, like what's the risk there, right? Because that certainly introduces its own risk with respect to like somebody with a mental health challenge who's going to this for support, and it's just saying, you're totally right about everything, right? That could be less helpful. Finally, this should just be, an across the board, hard line is like in these general purpose LLMs, um, the caveat, I guess, being like, OpenAI is starting to develop products for healthcare systems, so then it starts to get a little bit blurry. But like the chat GPT that you go on on your own, like on the internet here, like on your device, if you're at home, I guess, maybe you're not. If you're going on your own account, you should never, ever, ever input real people, clients' information. Um, for those systems, they might say, hey, like you can just turn off chat history, turn off the training. But like, with ChatGPT specifically, like there's this lawsuit where they actually still have to hold on to the temporary chats until the lawsuit is resolved. And so like Sam Altman himself, we'll talk about tomorrow, has said like, hey, like we don't actually know like what people can and can't do with this data. So like you should be careful. So if the CEO is saying that, it's a pretty good sign that we have to be really careful about client information, obviously. Any I don't know, any like reflections, or like are people doing things besides these things that they want to kind of name and say, hey, like here's another thing that you might use ChatGPT for that I found it useful for, or another kind of consideration that we're maybe glossing over. And obviously, I'm using the word ChatGPT as shorthand to mean, these things more generally. Um, but if not, I'll have a bit of a demo that I'm hoping people can, we can do some back and forth with. Yeah, so treating it like a conversation's got a thumbs up. Yeah, agreed. I find it much more helpful that way. So I'm gonna exit my own thing here. Thanks, Kim. Thanks for joining. Okay. This is where I wish I had two screens because I want to involve you all. So I'm going to, or we together are going to generate a client handout. Thanks, Laura. Okay, so I think I can see people. I think I can see the chat, and if actually people can just pipe in. But let's pretend that we're creating a psychoeducation handout together. Does somebody have let's say, a population that they work with that they would like, a handout for? Or we could start with topic or problem. I'm watching the chat here.
I can if nobody else is.
That's great.
This would be for the forensic population in a jail.
Mm.
And topic is insomnia.
Mm.
We are trying to limit how much medication we give for probably obvious reasons.
Yep.
And this needs to be probably at a 6th grade reading level.
Oh, that's great. Let's add that.
And I need to be able to upload it onto an iPad eventually, because I do receive those.
That is also very good additional context to say. So I need to it onto an iPad, which means like probably a PDF, right?
Yes, yeah, probably so.
Okay.
Or something that's slightly interactive. I don't know. I mean, this is where we're struggling, is to make it engaging.
Let's see. Would be ideal. Do you have a modality or approach, or do you want to keep it more general?
It can be general. Yeah.
All right.
Wide
So
open.
let's just take that out. Anybody want to add anything to this? We can do a back and forth with the response when we get it. So let's just see what we get. Trish, when you say we're struggling with, meaning you mean generally like in providing these kinds of
Yeah, it's probably the most common. Incarcerated individuals submit what's called sick slips, and is probably the most common topic that comes up is, and for obvious reasons. If I was in jail, I probably wouldn't be sleeping well either, to be honest with you. But they've lost all the primary reasons of ways to manage sleep, whether it be coffee, whether it be TV, whatever they may be using at home, they don't have anymore. And so the easy answer is just, I need medication. And we need to watch that. So we're looking for some more skillful ways of how to coach to do this.
All right. So Claude knows my name. Sometimes it gets my name wrong, though. Great psychoeducation. Yep. Realistic strategies rather than generic. That's good. Okay, so this is interesting. Many correctional tablets, maybe I actually want to check with you if this is true. Many correctional tablet systems run lockdown browsers that won't open standalone interactive HTML file, but reliably handle PDFs.
They're right. Geez, smart. Yes.
Nice. So a clean, visually engaging PDF. Nice. Okay, so we have three questions. Which format works best? Engaging PDF? Well, I guess we can't do interactive HTML. Yeah. That's kind of funny that it asked. Language?
Bilingual would be great.
Nice.
Yeah.
Nice. Include a short when to ask for help line. Oh, when to ask staff for help.
If they've not slept for several, oh no, these are just questions.
I guess it's saying, like, should we say, here's what you can do, and here's where it's bad enough to where you should ask for help.
Yes. If this does not assist, please put another sick slip, is what we'll basically be saying.
Why don't we say that? Yes. Include that if the strategies do not assist, they can include another sick slip.
Correct. Yes.
All right.
Oh, sick as in SICK. I'm sorry.
Oh, and so Sally said PDFs can open links, perhaps the nurse's office, or can create.
Oh,
Oh,
cool.
interesting. Um,
We're going to get real slick in our jail. Watch it.
so Sally, what are you saying? Are you saying that there's a website that they would be helpful to go to?
Just like a website, but just internal. So you don't want them opening
Okay.
websites because they're
Yeah.
they're not locked down. But they're within the intranet that they have there that they're allowed to access different things. And so it would just, click this button if you want this, or maybe click here and it'll create your six slip for you, and then it'll submit. Because unfortunately it's probably more second grade level that we're looking at generally, right?
So since I'm not connected to that system, I'm gonna say hypothetically, because probably if this was like plugged into the system, maybe it could create that link, right? So we could
But
have a
we'll pretend
button,
it could have a pretend button for this, yeah.
yeah, that
Dummy
connects
button, pretend.
to internal system for demo purpose, since I am not connected to system. All right, let's see what we get.
Because this could create that, but then, like Trisha's saying, this could be something that someone is perseverating on and they've already asked several times this evening, right? And so, yeah. This is cool though, right? This saves hours of time when you could be working directly with clients. Yeah.
Let's not speak too soon. It might be it might need a lot of work.
I'm going to be a superhero if you get this going for me.
We won't tell either, Trish. We won't tell.
Usually, and we'll see what we get here. Usually, like you end up with a place where you have something you can edit down, right?
Yeah.
Instead of like, okay, I had to do this from the ground up. Well, maybe they're saying it would work in HTML.
Okay.
No, who knows? Who knows?
Yeah.
This is kind of like the internet back in the dial-up days where you gotta wait.
Yeah, I know.
Which means in 5 years, this will happen instantaneously.
You're right. You're right. Yeah, and maybe this could have been like I'm using extra thinking, right? I don't, some things would probably be fun on high or medium thinking, right? But I find that it helps with, to have the first pass be, one of the better models, if that makes sense. So I have this other, if there's time, I had another prompt where, why don't I just do it on the other? Oh, okay, sorry, it's coming. Text forward educational handout. So a clean designed layout rendered to PDF will serve it far better than an art style canvas. Not sure what that is. Let me check my rendering tools and fonts. Let's just do 2 of these. I wanted to show you all another. We'll come back to that once it's fully loaded. I wanted to show you all another function that I think is really helpful. So it's this. So if you recall, we had on our slides earlier, is this study? Oh, we had the slide about the Limbic chatbot, and the limbic system for screening people. And so this is almost like a meta example of like using AI to learn about AI. If I don't have time to, read a methods section and understand the methodology. Um, so I'm uploading the research article. Give me a brief, plain language summary of the key points. And again, this is of that Limbic AI system. Give me the main findings, flag the limitations, caveats, places where evidence is weaker or more uncertain. Tell me what this might mean or not mean for behavioral health clinicians working in the community. That's a community-based mental health clinics. And let's let this run and come back to it, because hopefully, wow, okay, this is like really a warm designed bilingual layout, rendering to letter size PDF. Yeah, it's interesting. It is like the dial-up days, especially as things got, more, they're like more pictures and more sort of sophisticated websites. It's like the time that it's taking to, run the thing is going up. And once we were all downloading MP3s, you have to sit there or like let your computer run for several hours or days even. So you could make the argument too that like this is kind of straddling the line to agentic AI, right? Like it's kind of doing stuff, on its own, making decisions using tools. Um, all right, and this is what we have here. For people, is this like kind of big enough for people to see?
I think it looks good.
All right, so insomnia, a little bit of what is happening, why sleep is hard, um, some tips, right? Like, yeah, that's kind of the first thing that we say, right? Oh, happened. Yeah, waking up at the same time, movement, caffeine, skipping naps. Oh, and then there's this, I like the way that it did the bilingual, um, ask for help. You can't figure this out. So for the for Trish or others, like, are there things about this would we want to add anything specifically or remove anything?
I love that there's a tip at the very bottom, a real practical, the 1 minute calm down. We all have those skills. We all I call it square breathing and all that kind of stuff, but it's nice to see it like this. I honestly, I think having something like this, and I do like the way it did the Spanish and English, to be honest. You're not looking at translating 50 forms. You're not looking at it. For some, it may feel busy, but I think it's also kind of handy that way.
Yeah. And maybe let's say I'm a CBT person. I'm using CBT as an example. I'm not necessarily the biggest CBT person, but it does have a lot of useful kind of specific strategies, right? So I used to be able to just edit by highlighting here. So let's say add one tip that involves noticing and um, uh, addressing difficult thinking, i.e., CBT. So let's say we were somebody who wanted to make sure that that was included because maybe that's what we're working on with our person, right? So I'm going to come back to that because that's running. So now we have our plain language summary from our Nature Medicine paper on limbic access, self-referral chatbot. And we have summary, main findings, total referrals. I guess this was the paper where we showed, especially in, ethnic minority and non-binary individuals, it's still a little bit long, right? That was kind of by design because now we can, so there's evidence is softer than the headline in some ways. What does it mean and not mean? I don't know that I as a practicing clinician, maybe I don't have time to, kind of figure through all of this. So I'm going to say that's thorough, but it's a lot. Condense it to the 5 things a busy clinician actually needs to know and keep the most important. What is that? Were you right? Ask any clarifying questions that would, I think what happened, I must have pasted that into a different, okay. So I want to know the most important kind of things from this. So it's an AI chatbot, NHS mental health service website, walks people through self-referral. Like I said, referrals rose 15% with the chatbot, increased larger among non-binary, I think, minority groups. Measures referrals, not treatment, right? So that was like it's about the self-selecting in versus necessarily keeping, staying engaged in treatment. Gives you some information about reading the equity numbers with caution, not generalizing. Gives you a caveat. You could, so like I sometimes I get a little bit, wary because I've now kind of whittled this down so much. So I might say like, can you recheck against the paper and just make sure that you didn't misstate anything, right? Like that could be a follow-up here. But let's kind of look back on this one. All right, so notice and answer worried thoughts. At night, thoughts like, I'll never sleep feel true, but often aren't. Catch the thought, swap it for something calmer or truer, like, right? And so you could then say, oh, well, that's not exactly what I wanted you to say. How about just, say exactly this about CBT, right? Like, notice the thought that says blah, 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 instead of the one that you said, right? So, and I see that Nikki had to take off. Thanks, Nikki. We'll see you tomorrow. So yeah, pretty good. I will, Trish, if you'd like, I can send you the handout.
I was going to say, please do. I was hoping after all that I'd get this.
Nice.
Thank you.
All right, let's go back to our slides here. Oh, I think I need to share the screen. All right, so we've got 15 minutes left, and thought we could discuss what we just kind of went through, specifically or just more generally. After thinking about all the use cases, the scribe tools, the LLM systems, what's something that you are currently or are becoming more comfortable handing off to AI? Again, going into tomorrow, that's going to be more focused on safety, privacy, risk management from both our side and the client side. Putting out there what's giving you pause, if there's anything specifically, and then also just this can be a time where people just verbalize other thoughts or questions that you have generally, and if we can't answer them now, we can always make sure we do so tomorrow.
I think for me, it's almost knowing which AI tool to start with, and maybe it doesn't matter as much, but like I get caught in the web of, okay, do I do Gemini or do I, I was quickly writing down that you've got Claude Opus 4.8, and then I quickly Googled that to compare it against Gemini, and then I went down a rabbit, all in the meantime, in the last 5 minutes, by the way, I did that. And then I'll see these ads for cursive and that you should get some kind of certificate and you should learn. I think that's where for the administrative level of this, not the patient notes, not that piece that we're going to be hitting so much on tomorrow with responsibility, but more on what we just did, more on like onboarding, policies, procedures, spreadsheets, all that kind of stuff of knowing what to use for what, or maybe I'm overthinking it. And maybe AI can help me not overthink it. I don't know.
No, I don't think you're overthinking it. I think you're pointing to one of the biggest challenges, actually, which is that as this thing has ballooned so hard, and there's so many options, and the options are changing every day. Like one, knowing what's available, is just, you could literally you could read news about this or whatever, right? Like be on the AI labs websites every day, and there'd be new things to learn about, right? And that's just on the mainstream side, right? Like on the clinical side, it's like, we had the list of all the scribes, and you all named other ones, and there's probably more than, double the ones that we've named together, right? So knowing what's out there, is a big question mark. I think like I said, with the mainstream tools, I'm going to attach a link, for a resource that I've found helpful for kind of staying up on it. For the most part, you know, it, for the most part, like the main offerings, right? The Claude, the ChatGPT, the Gemini, they're mostly interchangeable, but people have preferences, right? So if maybe you use one for a while, you use one for another one for a while, and you might say, oh well, in my use cases, this one I like it more, but actually I like this one more for this other thing. But I think if you're using any of them and you're using any of the kind of most advanced version of any of them, you're probably doing pretty well. When it comes to the clinical tools, one of my goals for tomorrow is to help give us a language for evaluating them as they continue to come out, because it's impossible for us to be like, to make a determination about all of them, and that's going to not change actually, because they're also constantly changing, right? So, give us a language to be relatively confident, and at a certain point say, okay, I'm meeting my needs for this problem. Maybe we can come back to it and reevaluate the field, in some months, and also evaluate, the benefits and also challenges of the specific thing that we're doing, right? It's like maybe try it out for a while and see if that makes sense. But it's not a trivial question. It's not an easy question, actually. Probably the hardest one, I think. Anyone else?
Yeah, I'm wondering, in terms of, and if I missed this, I apologize because I did step out to go to the bathroom at one point, but in terms of like the environmental impact of this,
Mm,
is there anyone talking about ways that we can use AI in terms and maybe impact the environment less? Like, are there some
mm.
responsible ways for us to use it that, yeah, that aren't going to like massively increase global warming and destroy the planet?
That's a really good question, and I'm gonna prepare more to give you a better answer tomorrow, actually, because yeah, it's easy in these trainings to really just keep it to the clinic, right? But I know that people in our kinds of work rightfully are concerned with, the more macro level issues. And I want us to feel, either okay about what we're doing, or like know how to feel more okay about what we're doing. So, I will prepare for some response to that tomorrow. Thanks, Margaret.
I appreciate that. Thank you.
Yeah. Anybody else? All right. Well, we're about we've got about 8 minutes left. I won't keep people over if there's no other questions, but I see Sally, you just came on the screen. Did you? Okay. All right. Oh, and I see there's somebody in the chat. Okay, yeah. Thanks, Kate. Okay, cool. Well, I'm gonna actually drop my email in the chat too, in case anybody has anything else that comes up before tomorrow. And I'll leave my email too in the slide deck that you all get, just to make sure we can stay in touch too. So thanks for joining today, and I hope most of you can make it tomorrow. And if for those of you that can't, great that you were here. I enjoyed meeting you and talking to you all.